on the show, we are talking about a powerhouse organ which performs over 300 functions like filtering toxins, storing vitamins, and making proteins, and I can just go on and on. So, it is actually the metabolic factory of our body. And the best part about this organ is that even after a large chunk of this organ is removed, it can regenerate itself. Isn't it magical? Yes, we are talking about liver, and in Kannada, we call it yakrit. Talking about liver, it's tucked under your right ribs. Well, on a lighter note, you can live without your lover, but not without your liver. It's very, very important for survival. So, yeah, talking about liver and its issues, people in their 30s and 40s nowadays come with a lot of liver issues like fatty liver issues, hepatitis, and liver failure. So, on the show with me to understand our liver better, I have Aster Whitefield and Dr. H.R.S. Girn, Senior Consultant, Hepato, Pancreato, Biliary, and Multi-Organ Transplantation. Doctor, welcome to the podcast.
Thank you so much. Thank you so much for having me over.
So nice to talk to you about an amazing miracle organ which can regenerate itself. This, I think, not many people know that even after a large chunk of the liver is removed and it's been donated to somebody else who's in need, it can regenerate itself, and both the donor and the recipient will be healthy in a couple of months, provided they follow your instructions.
Yeah.
I was going through an article in which Indian government have said liver is one of the core reasons for almost 66% of deaths in the country. That's a huge percentage. So, in your practice of almost 3 decades, when people walk into OPD to meet you, what are the most common liver issues that they come up with?
We provide a very specialty care. We are a single organ care, liver, in terms of medical, surgical, transplant versus non-transplantation, liver cancer. So we do everything to do with liver. So the patients, by the time they come to us, usually most of them have been diagnosed with some form of liver disease or the other. Okay, but on a general basis, when the patients come in, and the first step might be they might have noticed that yellowish discoloration in their eyes, what we call jaundice. It may be when they have blood reports done that some of the liver enzymes may be higher, some of the reports may be deranged, or somebody would have had an ultrasound done due to any other reason. Okay, which could be any other doctor would have given a prescription for an ultrasound of the abdomen, and you would have picked up something like a fatty liver is the most common thing that you pick up. So most of the people initially come with this kind of a thing. That's one category. Our second category of patients who are direct referrals with liver failure. They may be ambulance transfers, they may be ICU to ICU transfers. And then we have a third category of patients where patients have been diagnosed with cirrhosis, and they have, besides the best optical medical management has not been helpful to carry this process further, and they come with a very specific requirement that they need now education or process how to be able to change the liver.
And as you rightly said, NAFLD, that's non alcoholic fatty liver disease, is so common nowadays. I'm sure the ratio doesn't justify, but it says 1 to 3 out of 10 have NAFLD. I'm sure the numbers are much higher because we haven't diagnosed all of them. And talking about a healthy liver, and for a healthy body itself, we need to have a couple of things in place, like a good air, which we are not breathing nowadays, good organic vegetables and fruits, which we are not having, and non polluted water. We are not consuming it. So, considering all these points, can we never escape liver issues, especially when we are staying in a place like Bengaluru, Delhi, Mumbai, these tier 1 cities?
So we have a very good data from USA in this. Okay, so now we know that about 2.7% of any country's population will have some form of liver disease.
Okay.
Okay, and out of that, fatty liver being the predominant. So it used to be called NAFLD, which was, now we call it MESLD.
Okay.
Okay, the terminology changed about 2 years ago. It's called metabolic associated liver steatosis, so it's called MESLD now. And but 2.7% is a staggering number when you consider any population. And out of that, 10% of that population will eventually die or have a significant liver related episode which will lead to a morbidity, mortality, in that setting. So the immense, I think we were not aware of it. I think the on a such a large proportion now, a lot of data and studies are coming, like you rightfully pointed out. Fatty liver is one of the most predominant things. So I won't call it MESL because I don't want to use technical terms, but I think fat related issues in the liver, this is now going to be almost on an epidemic proportion, not only with us but in the world over. And I think it's a good thing that it is getting recognized.
And when you talk about this being an epidemic, I think a lot of diseases or issues or health issues, as we call it as, is becoming an epidemic. And as you rightly pointed out, it will blow out of proportion and become a pandemic as well. Well, talking about liver disease, especially, I think it's a silent killer because unless people have reached the final stage almost, they would never know because they might ignore certain signs and symptoms like light yellowing of the eyes or the tiredness, fatigue, and they might ignore these things. And finally, when they come to the doctor and get themselves diagnosed, they're usually in the final stages. So that's the reason it's got this name, silent killer. So, talking about liver issues, has any particular case surprised you? Maybe they've come too early or they've come too late.
I think when you have a long career, you see almost everything that is possible in that specialty. I think what surprises me is the denial factor rather than any particular episode. I think people know when they have this particular side type of disease. I think the biggest surprise comes when people sort of ignore the ongoing process, and I think screening is very, very important. The surprises come in children, not so much in adults, because the amount of liver disease and the amount of fatty liver that we are seeing in teenage generations or in earlier age groups, I think that to me is surprising. I think that is a bit disproportional to the amount that we used to see even abroad. I mean, I worked for about 14 years in UK, and I think that is a surprise for me. Regarding clinical wise, we don't have many surprises now. But I think right now, even in 2025 with AI, and AI is one of the best patient advocacy tools, by the way, I feel. And I think people should use it more. Even in this thing, I think sometimes the liver care that we see in the community or in the periphery, or particularly in out of Bangalore or rural settings, I think that surprises me much more. And to be honest, liver disease is curable. You just need a timing for it. 80 to 90% of liver related issues, we have cure for it, depending on what stage the patient presents. But still, we don't have referral pathways for the patient to reach specialized teams early.
And as a bottom line, can we say do not ignore symptoms like fatigue, loss of appetite, and mild abdominal pain? Do you want to add a few more to this?
100%. I think we all know when our body is not functioning right.
Hmm.
I think our intuition is there. And I think once you feel that, I think people should at least get their basic blood tests done. And I think blood tests are not enough now. I think at least one screening ultrasound. And should you find any abnormality in it, now you can supplement it with the fibroscan, particularly when it comes to the liver. So I think ultrasound is not it's not one versus the other, but I think a basic screening for liver should include your blood tests, an ultrasound, and a fibroscan.
And as you rightly pointed out, this liver diseases, it's got age no bar. I think it's affecting all age groups. And since it's affecting children also, what is the cutoff age group that you would say from this age onwards, get your regular blood tests or get your tests done when it comes to liver? And which are the tests that you would suggest?
I think in children, I won't suggest screening children.
Okay.
I think most of the children who need transplantation or have severe liver disease, you would have picked them up when they're born. You would have children are followed and monitored very closely by the family, so you don't miss those diseases that much in children. I won't recommend regular screening, but what I would recommend, I think it just screening children for something which is lifestyle related. I think we have to work a lot on changing that lifestyle. I think with children, what I would suggest is that they should engage in regular physical activity. Childhood obesity has to be avoided at any cost, I think.
Because here parents think that if their children are bubbly, they're fat, they're good,
Yeah,
they're putting on
yeah,
good weight, it's good. They
yeah,
believe
yeah,
that.
yeah. Good weight is different, but
Yeah,
obesity is clearly visible.
correct.
And I think when that is happening, you have to inculcate that into the lifestyle from a very young age, so it becomes their habit. And I won't screen children, but I would take care of what they're eating. I would make sure they're getting some exercise. I would make sure they're interacting a lot socially. So right now everything is on phone, everything is on tabs, and I don't think. And also, What we have to realize is in the past 2 decades, India has gone through mass urbanization.
Mm.
So this urbanization leads to nuclear families, leads to lesser kids, leads to busier parents. So I think that quality of time interaction with the children and to find that routine with the children, I think that is very important. And
Correct.
pediatric liver diseases are very specific. They would
Mm.
get picked up. Fortunately, they're a very small proportion of children who would have those issues when they're born. They're metabolic errors. They are structural errors in the liver, or there are certain diseases that affect a very small proportion of children. But majority, I would say, just focus on lifestyle. I would start screening if somebody is not losing weight and it is
Mm.
clearly visible. Then I would suggest that they should get an ultrasound test done for even the children.
And from what age group do you advise the regular screening and tests?
I would suggest screening from about 30 years onwards. I know people say from 20, people say we should always screen, but you can't be a fear monger.
Correct.
Okay, we are also here to live. But I think in general, when you have life in moderation, I mean, if you look at the lifestyle of your grandparents and you look at your lifestyle, you know which diet to take. We all know that we have to exercise. We all know the need to go out and do that. These are things we always know. So the answer is I would start screening probably when we are around 30, 32, 35, like that. I won't put that pressure at a very younger age. I think that is kind of fear mongering. But I think we have to really, really push hard for a better lifestyle. We have to really push hard for cleaner air, for cleaner water. And I think those things will automatically lead to lesser diseases.
Doctor, does this advice change for high risk individuals?
No, high risk individuals are different. High risk individuals would be people who are consistently have high body mass index, high BMIs. High risk individuals would be, for example, in women, your pregnancy acts as an excellent screening tools. So every woman essentially gets screened for liver disease when they go through a childbearing age. So men essentially get screened through that probably later on in their life because they may have prostate issues or something. So everybody's going to get a scan almost a decade in their life. So I think the high risk individuals are people who have we have known that they have fatty liver, and they have consistently high BMIs. These are the people who at very young age have become diabetics, and these are uncontrolled diabetics. High risk individuals are also people who are consistently consuming huge quantities of alcohol. Okay, and which could be initially at a younger age we start because it could be peer pressure. It is us wanting to be popular. It is very acceptable in the house for whatever reasons. So these are what classify as the high risk individuals. Then we have a lot of drug menace now, which comes in. We don't have sharing of needles that much. I would classify them as high risk individuals as well, because the hepatitis can transmit like that, particularly B and C. So I think these are the high risk groups in general who we should screen much more regularly. And I would recommend a 6 monthly screening here, or at least a 6 monthly visit to your sensible family doctor. Every time it's not only tests, it's also taking history from a person, talking to a person, which would tell any good doctor that this is I want to screen and I want to keep an eye on this patient. So answer is don't ignore. High risk patients, usually the families will have to take responsibility. The high risk individual usually does not know they are high risk. They are in denial. And that is probably sometimes the beauty of human nature.
But is it mostly lifestyle related and not genetical?
No, I think both are equally important. So obesity can also be genetic. Okay, diabetes can also be genetic. Okay, and then we have very thin people who we will never expect, and they will have fatty livers and cirrhosis, and those are genetically predetermined. What we call as the lean mast cell or lean NASH. Okay, so lean NASH is a separate subcategory. So I think those are genetically positioned there, and some of the are the bile formation and bile metabolism diseases can be genetic. I think, but those don't fit into a general mass talk. I think those people we would have identified at some point or the other, and hopefully they would be being seen by a liver specialist from a very early stage and not at a terminal stage.
And talking to a liver specialist, we have to talk about liver transplant. And when we look at the history, the first human liver transplant was performed by Dr. Thomas E. Stars on March 1st of 1963. And the patient did not survive long, unfortunately, but then he achieved the first successful long term survival with a patient in 1967 again. of course, making a breakthrough in this field. And talking about India's success in liver transplant, India's first successful liver transplant, it happened in November 1998 on a 18-month-old boy. On a 18-month-old boy, Sanjay Kandasamy, with his father as the living donor, and the recipient is now a doctor, which is just amazing. So, talking about liver transplant, doctor, I think we've come a long way, right? From, especially in India, from 1998 to 2025.
India does the highest number of live donor liver transplants in the world now.
Oh, okay.
And we are one of the few specialties where on a regular basis we get people coming from abroad to train in India, not the other way around.
Okay.
Okay, the India didn't have a training system for transplantation for a very long time. I would say almost up till 2015-16. So it was an apprenticeship model. So anybody who's been a transplant surgeon before 2015 in India had spent a substantial part of their work life abroad. And it was a skilled transplants that came to India when the infrastructure was ready. So infrastructure in India was ready, but people were not ready to accept it because transplantation was never taught in medical schools. Okay, hepatology was not a subspecialty. Hepatology was part of the general gastroenterology and the general medicine, and you didn't have specialized platforms for these teams to come together to push the boundaries. Then the second big change in transplantation happened with government making amendments to organ donation rules. I think the government plays a very big part on setting up the lay of the land and the landscape. The governments in South India have been way more progressive than North India. So 90% of the cadaveric activity in liver happens in the three southern states as opposed to North. So there's a big discrepancy even in India. So infrastructure is not short, it's also the willingness to do something. And so multiple factors came through. And by the way, Starzl's first child was also a child. So I had the good fortune of meeting Dr. Starzl twice in my life. Okay, first time was when I was training in Leeds, which is my alma mater. He came and planted the Starzl tree there, and then he came back again to visit. So I was a fellow at that time, resident at that time. So it was a very exciting time. But it is his journey, and if you read his book, The Puzzle People, he talks a lot about it. And again, most transplanters were fascinated that an organ doesn't die. Person dies, but that organ carries on living another 50 years or 30 years or 20 years into somebody else. I think if you think about that as a fascinating concept, and then you see it about organ donation as a part of the biggest form of sharing a society can do. So it's like passing the baton, just like what you see in inheritance. I have used that organ. Now I've passed it on to somebody else. And I think if you see it from that and you see the utilitarian concept of an organ, where God intended it to be in one person for a certain number of years, but it carries on in the other person for the next set of years. I think those are very fascinating things. But I think fascinating things and that kind of thing to percolate it into a societal benefit, it's a very big drive from government things. It's a very big drive on public government partnerships. It can't be government versus private. It can't be government hospital versus a private hospital when you are talking about a societal resource like an organ. And I think those partnerships have flourished a lot in the southern states. And I think Bangalore is a fantastic example of that, where everybody works together, everybody comes together, there are regular meetings, and it's a very, very transparent system. Because unless you maintain the transparency, why would people have faith in that system? And having said that, uh, it's an unrealistic expectation that every person is going to get an organ. Okay, for example, if you now we say that in 2025 we are a very modernized country, but when you look at the societies in Europe, or we look everywhere from organ donation perspective and alone, uh, Spain has about 32 organ donations per million population. Okay, most advanced Western societies would be ranging from 20 to 26. In India it is 0.8 per million. Okay, and that is including the corneal donation when you look at the pan India perspective. Now, cornea is a tissue, it is not a solid organ, because solid organ can only be utilized within 4 to 6 hours or 8-hour window. Cornea can be stored for up to 2 years. Okay, so when you look at that perspective, the solid organ donation in India is almost a zero 0.2 per million population. And we just talked about that about 2.7% of the population of any country is going to have some liver related issue. 10% of the 2.7% are going to succumb to liver related disease. And then we have an organ donation rate of zero 0.2, solid organ donation rate. Now, in the southern states, that rate would be much higher. Okay, but southern states take the burden of entire India.
And also, getting a match is a challenge, right?
Match is a challenge. It is sustainability to be able to wait on the waiting list. I think that's the biggest challenge in liver. Liver doesn't have dialysis like kidney. So either a person is put on the waiting list about a year, which I think is a realistic time for them to potentially have an organ. It will not be in their hometown. It could be anywhere in India when I say 1 year. And 80%, 90% of those people are going to travel to one of these 3 to 4 states and be put on a waiting list somewhere else. So you can look at the cost implications of logistics and displacement of a family, okay, and maintenance on the waiting list. So as a result, live donation is going to be the backbone now and for the foreseeable future till we have much bigger government private engagements, till this organ donation burden is shared by the entire country, not just a few states. And those are theoretical discussions as of now. They may happen when they happen, but for now, in the near future, when somebody needs a transplantation, they have to think in terms of live donation and cadaveric. It is not one versus the other.
Yes, doctor. Awareness on this is very much needed.
Yeah, and about 20% of people pan India, 1 in 5 patients who are on a transplant waiting list. I'm not saying a liver patient. These are the people who have been referred for transplant surgery with the specialist center. 1 in 5 would get an organ. Okay, so I think it's a good thing to address that it's an unrealistic expectation that everybody would get an organ. So people should consider live donation and cadaveric donation, not just one option.
Yeah, though the percentage is like very, very low. Uh, Talking about liver transplantation, the success rates are really high now compared to what it was in 1998 when the first surgery happened on an 18-month-old baby. But still, I think a lot of them fail when it comes to post surgical treatment because they'll have to take their medications properly and their lifestyle has to be corrected post that. Do you think most of them fail there, doctor?
I'll address it in a slightly different way. Okay, when people talk about transplant surgeon, people only think that you provide a technical service of taking an organ out and putting another one in, i.e., as we call ourselves, human plumbers. Okay, but about 80% of patients who come to me or to our department, they get seen by a team. So the team is myself. There is a hepatologist. We have counselors and dietitians. It's a whole thing. Hepatology is a subspecialty, single organ, specialty, just like transplantation of liver. So when they come, about 80% of patients are actually managed medically because they come to us in varying stages of the disease.
Also, doctor, though liver transplant surgeries are usually successful thanks to the medical advancements, do you think comorbidities makes it very hard because in India we see a lot of people with BP and diabetes?
So anybody who would see, first of all, I would like to stress that the transplant centers are usually very well equipped in a multi-speciality fashion. And number two, anybody who's had chronic disease would have some issues associated with it. But that doesn't really impact on the transplantation because you would have done the risks assessment before and you would have pre-optimized the patient. And if somebody has significant heart issues, significant lung issues, then those are not candidates for transplantation. That is what the screening and the initial referral and the workup is for. And I think we counsel and educated the patients a great detail. So most transplants would have a 95 to 96% success rate. And we are very fortunate to be a high volume center in Aster. So, last week we are the first center ever to have done 100 transplants in Karnataka ever. In fact, we didn't know that we had done 100. Okay, but a team manager knew the numbers, and then afterwards we were seeing some text on the phone. But there it is. So I think the centers transplant should be done by high volume centers to achieve that success rate. And when we looked at our own data for the last, I would say 500, 600 transplants that we have done here, we've done more than that. We've done nearly 1400, 1500 transplants, but we have a good data, robust data for the last, since 2020, I think. Uh, when you look at the long-term survival, it is nearly about 75% in India. Okay, even in India.
Okay.
And the 1 year survival is about 95 to 96%. Okay, somewhere around there. Ballpark figure 90% people will make it. But when you consider that these patients, if they didn't get a transplant, they would have 100% death. And they would have spent the same amount of money in various ICUs. Okay, so the relative benefit is 90%. And the people who wait for the cadaveric transplant tend to be a lot more sicker. Because if you had a live donor in the family, you would have worked up both the donor and the recipient, and you would have had a window of opportunity when the patient is stable, and then you can carry out the operation at that time. When it comes to cadaver, that window of opportunity is not there. You're going to get an organ, you don't know when you're going to get an organ, and what your condition is that day. Okay, and also when you're waiting on the waiting list, essentially the liver disease progresses despite whatever you may do, and about 20 to 30% patients or more die on the waiting list. Okay, so because there are only finite number of organs to be able to given to the rest of the people. So I think those are the challenges that we face on a day-to-day thing, and those are the challenges we discuss a lot with our hepatologists, with the governments, and with the state organ transplant organizations. And luckily, we have very good platforms, at least in Bangalore, and the government does an immense amount of work for the patients, unheard of. When are not talked about much, but behind the scenes, there are regular meetings, there are regular organ sharing meetings. And I think that's how you progress.
And talking about donor and recipient, I think mostly the spotlight is always on the recipient, but not many people talk about donor because
Yeah,
they
yeah,
also need
yeah,
the post-surgical
yeah, yeah,
recovery time and that
yeah,
caregiver's
yeah,
burden. They
yeah,
experience that along with
yeah.
they have to recover.
So there are three important things I'll highlight here,
Yeah.
and which repeatedly we talk about to our patients. So when somebody potentially feels they need a liver transplant in the year, 6 months, year, or they're going down that route, what I always advocate people is work up a donor at that time. Because what usually happens, you work up a donor 1 week before the transplant. So for me, donor is the most important person in that room, in that operation. So donor is a person who has no disease of the liver and is undergoing a major surgery just to be able to help a loved one. So, we may talk about cynical things happen in the world, but if you think about the beauty of it, we see the best of love between brothers and sisters. We see the best of love between parents and, children. We see the best of love in terms of the whole family coming together to help somebody. And I think you see a very, very interesting and a beautiful side of humankind in that. But what we do, or our policy at Aster, or we try and counsel people, not every time people listen, is to work up the donor when you think you need a transplant, because donor also has time to optimize themselves. So why is it mandatory to work up a donor and transplant 10 days afterwards, when if the patient is stable, the donor is worked up, they have had all the tests done, and we know they're suitable, they can also make their health better along with the recipient, and when the need comes, you can change the gears and carry on with the transplantation. So that is a huge caveat, and which I struggle at times. So the donor health is very, very important, and that is, in Bangalore, that is 50 to 60% of our activity is doing live donor transplants.
Okay.
And donor health, you're absolutely right. I think pre-optimization and workup, it's a major surgery. It is not a small surgery. It is a surgery done on somebody who has no disease. So as a surgeon or as a team, it's a huge amount of pressure. So first of all, what I feel is that you should have very experienced team who do this in and out. The high volume teams will give you much better results, and I think people know that, and they come. Okay, accordingly, when somebody reaches the stage, they'll search, they will look, and they will look at your track record, they look at the experience, all those things have to match. And then there is a lot of emotional angle to it. Okay, donor has a family, and even if somebody falls in a pond and somebody picks them up from the, can you imagine the amount of recognition they get in a village? So donor is an unsung hero.
Correct, correct.
Okay, or heroine. I
Hmm.
don't want to be gender specific. And
Huh.
so I think that is a big responsibility. They have to be counseled. They need emotional support. Okay, and they need a thorough counseling in terms. And my job as a transplant surgeon is to make sure they go through that huge turn around in their life in a safe way. In the long run, unfortunately, donor has no issues. Okay, they will have. In fact, most studies have shown donors have better health than general population. Not because that you've done anything specific, but anybody who's undergone a major surgery, they're going to take better care of themselves as compared to the rest of the population. So I think I'm glad you brought it up. I think transplantation is only possible because of the donors. Otherwise, there is no transplantation. And I think any transplant team takes this very, very seriously. And obviously, you have imaging advances. You have advances in the surgical technique, you have advances in experience, and you can have minimally invasive techniques like laparoscopic or robotics, which you can add on to that safety and convenience of the donor.
So, Dr. H.R.S. Girn, who's an expert in liver transplant surgery. So, most of us who are watching this, we do not want to get there in the sense to get to that state. So, to sum it up, we'll have to have a good lifestyle. We should maintain an ideal body weight, BMI, right? And having good food, getting good exercise, getting exposed to the sunlight. It's also important. But then let's address the elephant in the room. How much alcohol is too much alcohol?
So nobody really needs alcohol. Okay. So I think the answer is that you don't need to drink. But again, binge drinking is definitely harmful.
Hmm.
No one alcohol is better than the other. Your liver does not have a brain of its own. It only needs ethanol, and it only metabolizes ethanol.
Hmm.
It doesn't know whether it's vodka, red, white, blue wine. It doesn't know whether it's a single malt, whatever it is. It goes by the quantity and the regular insult that it has to go through. So I think the three things are binge drinking is really bad. Okay, social drinking, yes. You don't have to do it, but should you indulge in that, give yourself breaks. Okay, if your liver tests indicate that there is something going wrong, there is no bravado in carrying on drinking. That is one definitive reversal that you can achieve. Okay, alcoholism is a different issue. So, alcoholism is a psychosocial disorder. I mean, these people are going to need rehab and they need massive amounts of counseling, and that's a different story. But for a general person, take care of your health, be in moderation. Ideal body weight nobody achieves. Okay, but it's an endeavor to keep on trying to achieve it, and I think that will keep your liver safe.
Doctor, talking about costs, we are sure that insurance covers it, but as you rightly mentioned, that the percentage of organ donors are so less, so little in India. I think it's the same with people who have insurance,
Yeah,
apart from people who have insurance from their companies,
yeah,
right? So, do you want to address this costs part? Because I'm
yeah,
sure everybody would ask you this
yeah,
question
yeah,
first once you say this person
yeah.
needs a liver transplant.
One, the cost of liver failure and cost of transplantation is the same.
Okay.
So what I tell people is people spend the same amount of money in the final couple of months of their life in different ICUs as would be the cost of transplantation. Second, insurances are still not mature enough in India, and 80 to 90% of transplantation is self-paid. We are working with the insurances. I mean, about 5 to 10% insurances now cover, which was not the case 10 years ago. Okay, so insurances are just about getting in there, but it's a long journey ahead, and that is something, a rule of again continuous engagement, where we feel it can get covered. Cadaveric hardly any insurance covers. It is essentially all the family is paying. So along with the cost, the other thing is that there are alternative sources of funding. So we do that a lot in our pediatric patients. So right now we are in a situation, particularly in Aster integrated liver care in our hospitals, irrespective of the cost, we would be able to transplant a child. And it is not a charity, because how do you give quality by cutting down the cost? You cannot. How do you get the best of personnel still treating the patient, operating on the patient, and maintaining the patient throughout the journey in the hospital So answer is not discounts. Answer is to generate an alternative source of funding. A transplantation has a fixed cost. A quality drug is going to have a fixed cost. A quality suture is going to have a fixed cost. Child may need dialysis, child may need CT scans. You cannot cut down on that. So we have a very robust crowdfunding model. Okay. And then we work very closely with a lot of CSR groups. And over years, there's a trust building where we give them our results every 3 to 4 months for all our children so that they know what's happening. And now through this model, we have been able to transplant, I think, nearly around 115 to 120 kids for 10 crore rupees. And so the cost of a child in our unit comes to almost 2.5 to 3 lakhs or whatever the family may have. That is not the entire pediatric work we do, but that is about 30 to 40% of our transplants. So the point I'm trying to make is not what we do. And our case is getting studied by IIM Ahmedabad. So answer is not discounts. Answer is to find alternative sources. Answer is to engage a lot more with insurances. When you are taking on an insurance, this is something you have to discuss with them at the time you buy one. And you have to choose your vendor accordingly. So just like anything in there, but it is now coming to fruition. Cadaveric transplant essentially works out a lot more expensive than a live donor transplantation.
Doctor, this was an extremely insightful session, but can we end this podcast with a simple tip or trick for a healthy liver from your side?
Live life in moderation. Seek specialist care early. Okay. And specialists in liver disease are hepatologists and transplant teams. Transplant teams, it doesn't mean that you're gonna go there, they're gonna operate. 80% of our work is actually non-surgical work in assessing and taking care of patients at different stages of disease. When you're taking your insurances, read and discuss clearly. It becomes a very big issue. And I think in general, remember, liver disease is curable. A cure is when a person comes to a doctor and he goes back, he does not have the disease. We don't have answer in many things in medicine. Thanks to what you mentioned, Dr. Starzl, right now, cirrhosis is curable. And we can change the prognosis from 100% death to 90 to 95% survival, not just immediate, but next 10 to 15 years. And not just a bedridden patient, a productive member who goes back and in 3 months, if he's a farmer, he does farming. He's a sportsman, he plays. He's a doctor, he operates or sees his patients. He's a software engineer, he does what he wants to do. I think how many times can you say that? And you carry on being part of the journey of that patient throughout to maintain his liver afterwards. And the maintenance is usually 1 to 2 drugs for the rest of your life and regular screening every 6 months. And before you need transplantation, you were getting screened every 15 days. So I think quality of life improves, and I would like to end up at that.
So choose the hospital and your doctor wisely is what I would like to end this podcast with. Thank you so much.
I think choose teams well. I think transplant is a team sport. And choose teams with bigger numbers, and because that's where the experience and volumes are going to add to experience.
Absolutely, sir.
Thank you.
Thank you so
Thank you.
much.